Good evening and welcome to everybody who took the time to come here tonight. You're all very welcome, and I hope that you find the presentation informative and useful. So for this series, what I'm going to be covering is the addiction and the pathway to treatment in St. John of God Hospital Addiction Service. So I'm going to be talking a little bit about addiction. As we know, addiction is a very complex, vast area. So I'll just give you a very brief overview of addiction, and then I'll move into the actual pathway of treatment that we use on a daily basis here in St. John of God Hospital. So sometimes I think it's helpful to start with a definition of addiction, a simple one, you know. And if we look at this one, addiction is the repeated involvement with a substance or activity despite the substantial harm it causes. So, you know, it's a small definition, but it says so much, you know, that people in addiction continue to use long past the point where they know that they're harming themselves and others. So that will speak to some of the huge power of addiction. Just to tell you a little bit about the pattern, the progression of addiction. Early use brings good feelings. I suppose any normal drinker would say that it's a good feeling. But with somebody who's addicted, the abuse is understated, minimised. Defences start to creep in. People start to rationalise it, minimise it. Lies are told to protect yourself from the family. Negative effects are blamed on someone or something else. Something like, we might hear somebody say, well, if it wasn't for the job I have, I wouldn't need to drink so much. Or if I wasn't in this awful marriage, I wouldn't need to use, you know, that kind of thing that they at the time they genuinely see it that way. Reality becomes distorted and there's a loss of real feelings. So with addiction, really there's a numbing out of all feeling, and that's kind of the task at hand, that's why people would use, out of a sense of emotional pain. And people end up confused, there's a loss of control, and life becomes unmanageable. So some of the physical signs that can be associated with addiction, these are just a few, there are many more, but just to give you an idea. Bloodshot eyes, sometimes that can be to do with drug use. Nosebleeds to do with cocaine use. Changes in appetite, sleep patterns. We see that a lot. Patients will come in and they will speak about their sleeping pattern being shot for years sometimes, and it's because they've been using, you know, their drug of choice to actually get sleep. So that takes a while to recover, but people do. And then a very serious sign is seizures without a history of epilepsy. So that has to be medically monitored, and we have dealt with it here and then sent people out to the medical facilities outside. Few more signs. There can be a deterioration in personal grooming, or sometimes I would say there can be the opposite. There can be a kind of perfectionistic way of living. Everything is taken care of. People are never late for work. They're never seen to be, you know, in any turmoil. But maybe when they get home at night, that's when it starts. You know, it can be isolative, drinking on their own, using drugs on their own, gambling on their own. So, you know, it's not always hard to tell. It's not always easy to tell. Injuries, accidents, the person can not tell you how they received the injury. Sometimes that can relate to blackout drinking or blackout use of substances. So sometimes families get very frustrated when they hear people talk about, you know, not remembering, but the truth is they don't remember. They actually have no sense of what was happening at the time as a result of the power of the substance. Unusual smells on the breath. So that can be from cannabis or hash use. Shakes, tremors, incoherent or slurred speech, impaired or unstable coordination. So sometimes you see people who come in and their gait is really off. So, you know, if you ever see somebody who's had a bit too much to drink, they kind of start holding onto walls. It's the same kind of thing. but then that often improves quite quickly. So before I just get into that, just to say a little bit about behavioural symptoms, and to stress that the behavioural symptoms are behaviours. That's what they are. They're not indicative of the essence of the person, but it's what people are driven to do in order to get what they need. And that can be, lying, cheating, manipulating, maybe something more overt like drink driving. I mean, it's interesting to note that 2 out of 5 fatal collisions in this country, 2 of 5 out of them are alcohol related. It's a high figure. So some examples of process addiction, and when we say process, we mean that you're instead of imbibing a substance, you're actually physically carrying out a process to get the same kind of reward or high. Gambling, so that would have the effect of numbing, or looking for the high of winning. Then because of the despair of losing, you have to go again. Food, compulsive overeating, restricting of food, exercising. Exercising to the point of obsession, so that your body could be in pain, but you're ignoring the signals because your mind is so intent on continuing the exercise. The internet, of course, as we know, is a huge issue today, and people would look at porn and all sorts of other stuff that they become addicted to. Can everyone hear me down the back? Yeah. Down a bit, yeah.
Yeah, just
I'm not lost.
maybe just.
That better?
Can everybody hear down the back?
Yeah, that's better. Okay. So as with chemical addiction, process addiction can help meet a need to cope with stress, manage emotional pain, and cope with negative feelings. So you can see the power in it. You can see why people would start to look at addiction as a self-soothing mechanism. Obviously, to their detriment over time, but you can see the pull. So we often talk about the deadly trap in addiction, It's almost like as the emotional pain increases, the person finds they need to use more and more of the substance to numb out the feeling. Then, of course, that wears off and withdrawal comes in and can be very unpleasant. So the person needs even more of what they don't really need to take, but they have to take to settle the withdrawal and help the stress underneath. So it's like a vicious loop, and it's really, really hard to get off of that loop by yourself, which is why people do come in for treatment, and it's pretty difficult to crack addiction on your own, especially in the progressive stages, the late stages. So that's a little bit on addiction, and we'll talk a little bit about the staff team here on the addiction unit. You've just heard Dr. Colin O'Gara there. He's the consultant psychiatrist. He's the head of the team, and he's a specialist in the area of addiction. We have 2 registrars, and then we have 4 addiction counsellors. So there's myself, Margaret, Kathleen and Mary. And then we have Dr. Amy Watchorn, who is a senior clinical psychologist and who provides very important input into some of the more complex cases, for instance, dual diagnosis patients. And she also does assessments. We have a full complement of nursing staff. There's Donal and John are the clinical nurse managers, and then we have nurses as well who are pretty much, there's nurses there 24/7. And it's very useful on the weekends, actually, when patients go out, because they often do use the opportunity to ring in if they're feeling a little bit wobbly, and that's very helpful. Then the other person we have is Scott Hill. He's a senior social worker, and he works with families in particular, and Family Day as well. I'll talk a little bit more about him as we go on. Father Hugh and Maureen McCabe provide pastoral care, and Maureen in particular provides bereavement support for people who have particular bereavement issues that they can be addressed while they're here. The complementary therapists are Chris and Mary McCormack, Caroline, Geraldine, Joe, and they do Pilates, mindful body work and yoga. I actually love this part of the programme because I think it's inspirational, because in a way that part of it addresses something that is so much a theme with people in addiction, which is the running and racing and the drivenness of it. So you'd often say there's a feeling of driven and exhaust. So when people come into us, they probably haven't really stopped at any point in their life, in their adult life. So this is a lovely way of slowing down the mind. It gives people a chance to kind of come back into their bodies almost. And although they seem like lovely, things to do, they're actually quite hard to tolerate for some people, who find it hard to sit still and be with the mind, but they're very, very effective, and we get a lot of positive feedback on those. So it's just to say a little bit about referrals. They will come in from GPs nationally, internationally, UN European, the Middle East, self-referral, and also internal from other teams. So there's a combination of all of those. Now we'll just talk a little bit about patient treatment pathway. So it starts really with the referrals, which are received by our admission office, and then they're passed on to Dr. O'Gara for approval. The person comes in onto St. Camilla's ward, and an assessment is undertaken. So this is done by the nursing staff, and it determines the immediate treatment needs, and they establish an agreement for the therapeutic interactions. So just so the patient gets a flavour of what it is they're coming in to, and to sort of ease their worries. Because I always think it's extremely daunting for anybody to come through the gates of the hospital suffering with an addiction. Because in many ways people may have been struggling for years in that pre-contemplation place. I'll do something about it next month, next year. I'm not that bad yet, I'll wait. So when they come in, they really are very vulnerable. So we have a great team of nurses to help with that. They're the first point of contact, and they assist in easing the fears of the patients. So that's a bit wordy, but just to kind of briefly say, the nursing staff liaise with families, getting collateral, discussing treatment options, all of the stuff in the early days. The nursing staff then commence a prescribed medical detoxification, which is tailored to each patient. The patient is closely monitored at all times, and if there are withdrawal symptoms, then the 2 registrars are on hand at any time to support the patient and look after them. And also Dr. O'Gara is around. The nursing staff engage with all patients in a supportive and non-judgment way, and they're offered one-to-one time. And, patients have often said to us, it's quite a common thing to say, when I came in here, I was terrified and I was expecting the worst and I thought it would be hell. And they're kind of really surprised that they were treated with such kindness. So that's lovely to hear, and as it should be, really. So the nursing staff liaise daily with the members of the team, especially the addiction counsellors. And there is a senior addiction counsellor, Margaret, who works with the patients directly on the ward as they're preparing for the programme. The nursing staff continue to provide support through detoxification and support until the patient is ready to join the programme. Also, families can ring in quite a lot in the early days, naturally, because they're anxious and it's, a lot of the unknown. And again, nursing staff are always there on the end of the phone to explain what's happening. Confidentiality is key, but they can definitely help to allay a lot of their fears. Nursing staff will assist patients to ensure compliance with medications, liaise again with the addiction counsellors, and they are the first, continuous and last point of contacts for all patients. So in saying that, really the nurses form a connection with the patients that follows all the way through, and that can be, very helpful to the patient. So moving on now to say a little bit about the addiction treatment programme in itself. It's a holistic treatment approach, which means that it's non-judging, non-confrontational. And we have found under Dr. O'Gara's guidance that this is an approach that works, and people respond to very well. And sometimes, we see that patients will challenge themselves way more than the clinicians will because of that approach, because they're given time to reflect. It's person-centred treatment, and we draw on therapeutic modalities according to the unique needs of the patient. So it's tailored to each patient, and we try to meet each patient where they are at in the progression of their recovery or their addiction, where they're starting out, their history, all of that, because everybody is so different. We work with patients presenting with dual diagnosis and polysubstance drug and alcohol and behavioural addiction. So that would mean, benzodiazepine misuse, prescription drugs, over-the-counter drugs, drugs bought on the net, that kind of thing. The programme, at the heart of the programme then, there's a focus on establishing the relationship with the patient and the core conditions of, the non-conditional positive regard for each patient, and the empathy that will go with that. And being cognizant of development issues and the impact of same on the nature of the work. Because again, everybody will present to the hospital with a different story. And, I often say to patients, they'll say to me, well, I'm not as bad as so-and-so. I didn't go as far down, or I don't seem to have lost as much. And I always say to them, your story is the worst you've ever heard because it's yours, And so everybody is treated in the same way. So the model that we work under is the biopsychosocial model of treatment, and breaking that down a little bit, it's biological, which mainly treats the effects of addiction. So there may be a need for medication for psychosis, mood disorder, ADHD, that kind of thing. Then there's psychological, psychotherapy, psychology, assessments and one-to-one input. And social is the need for change and to build a solid network of support in early recovery. Some of that is Scott Hill is very helpful with, but also we actually tap into that fairly early into the 28-day programme by working individually with each patient on a discharge plan. And the discharge plan is crucial in terms of addressing the social changes that they will meet and the challenges they will meet. Like an example would be somebody who's been drinking for a very long time and their life centred around, say, the pub 5 nights out of 7. Well, obviously that's going to leave a vacuum. So life will change. So how then can they adapt to the change with alternative, healthier sorts of ways of, being in the world and finding pleasure in things other than using or drinking or gambling. So we liaise closely with the multidisciplinary team, drawing on each individual's clinical experience, which I think is really helpful. So at every meeting, everybody is heard and we get a perspective from each clinician, and then with the patient at the centre of that, of course. Family is involved and supported as part of the treatment all the way through. They're very welcome to phone, to come in for meetings, whatever they need. And we support patients to develop insight into addictive behaviours to elicit change. And I guess the word insight is really crucial, because sometimes people, you know, and it's understandable, can tend to say, the person knows what they're doing. Sure, if they know what they're doing, can't they just stop? Can't they see that they're harming themselves and others? And it's not as simple as that. If the insight isn't there, it's almost like the person is acting out of the unconscious. So they're not willfully going out to harm themselves or other. But when the insight starts to crack the denial, then the clarity comes, then the awareness comes, then the reality of the harm done comes back, which can be very painful for patients. But at the same time, it's the beginning of the road to recovery, where they can actually see the true picture and not the distorted picture that the addiction creates. And their patients are always encouraged and supported as they make these changes. So just tell you a little bit about Family Day. We have that twice during the patient's treatment, 9:30 to 1, 2 weeks apart. So there's 3 parts to the morning. We see family members first for an hour, and that's just really questions and answers, and you know, anything that the families are unsure about or worried about. Then we have a presentation for an hour on addiction or recovery, and then the patients leave and we have a wrap up with family, and usually there's a lot more questions then, and we answer them. And also it's a lot about self-care for families, so we will offer support for them and suggest support services like Al-Anon, which are fantastic for working with people who have been affected by addiction. So it's all about, Family Day is about acknowledging and normalising the feelings. Families will often say to us, you know, I got a lot from the information on the day, but what really helped me was sitting in a room with other families and listening to them share my story, because I felt so alone with this. I didn't think there was anybody who was going through this. I didn't think there was anybody who felt the shame that I was feeling. And that can be very, very healing. So in that way, it's a really positive morning. So the patients start the 28-day programme, the first weekend in hospital, and then the 3 subsequent weekends out. The rationale behind that is that it gives patients a graded exposure to the outside world. Because when you think about it, they are going to have to face that in 28 days. So it's a really good idea to give patients the feel for that, and you know, to get a sense of what are the environmental triggers, what are the emotional triggers, and when they come back, we will always review it on a Monday in a process group. So that can be very useful for people who say, well, that weekend didn't go well, I found it very difficult, I was craving, or I don't know, I was in Tesco and I was at the drinks aisle and suddenly, you know, I felt I wanted to murder a drink. You know, these are all things that are so normal in early recovery, and then we can talk through ways of managing that. So patients plan for discharge during the treatment programme, and we help them one-to-one alongside that to formulate a realistic, practical discharge plan that will work for them and will fit into their busy lives. We do recommend that patients attend mutual support groups, because we've seen over time that they work. So when we say support groups, we mean AA, NA, CA, and LifeRing, which is a mutual support meeting that's on in this hospital 3 times a week, and patients speak highly of that. AA also has worked for a very long time, and its longevity speaks for itself. It's been going for more than 83 years, started in 1935, and there are countless people around the world who have stayed clean and sober as a result of attending meetings. So we do recommend them. We don't push it, but we talk about the benefits. And I suppose the thinking is that repetition brings recognition. So the patient will meet with the team prior to discharge. They can ask any questions they wish. talk about their care. We do suggest outpatient appointments with Dr. O'Gara because we find that people do very well. There's continuity. They're under the care of the hospital. And if the person, is feeling a bit wobbly, they know that all they have to do is phone in and make an appointment with Dr. O'Gara. So there's a kind of a safety net. The aftercare programme in the hospital is run by Margaret Doheney, and that's also a very good option. It's once a week for a year, and there's a lot of power in that because people who maybe have gone through treatment together get great support from their peers, and there's a feeling of being in it together, as they go forward through the year, and it really builds confidence. So almost there, just social work role and psychology, and we'll wrap up. So social work role, that would be Scott Hill. He's our senior social worker, and he does a fantastic job of working with families all the way through admission from start to finish. He provides individual family members with support. He facilitates open communication, and he's there on Family Day and presents alongside the counsellors. He supports patients throughout admission in managing relationships. And what I like here is, talking about breaking the ice with the open communication. A lot of times, because addiction is a family illness, there are no winners, everybody suffers. The communication can be at an all-time low. There's either full-blown chaos or nobody is talking. And then, if things blow over, everybody is afraid to talk. So, people get out of the practice, or they just don't know how to relate to the people they love. So, the family meetings that Scott provides are the really first, sometimes the first good step in a long time that families can speak to each other and really hear each other. And I've seen that process work really well with families. The psychology role is filled by our senior psychologist, Dr. Amy Watchorn, and we're very lucky to have Amy because her role in the team is to work with complex cases. So she does assessment, consultation and intervention in these cases, and it can include patients presenting with, for instance, dual diagnosis, underlying personality vulnerabilities and queried cognitive deficits. So Amy will meet with those patients after a meeting with the team in full. It'll be discussed, and then Amy will meet for an assessment which will include cognitive, neuropsychological, personality and psychological assessments. And that's done while they're going through the programme at a time that suits them. And then there's a provision of support and onward referral to OPD, psychology service as required. So just, a bit like outpatients with Dr. O'Gara, there's that continuity of service that Dr. Watchorn can offer, and patients will often say, it's great to know I'm coming back to somebody I know, who knows my history, who I feel is, has my back, and I can call on if I need them. So that's a very, very quick whistle-stop tour, and thank you for listening.
So first one, and this is all anonymous, that's the whole idea with it. So is there any best way or recommended way to discuss heavy drinking and smoking directly with the addicted person? So is there any best way or recommended way to discuss heavy drinking and smoking with a person? If you can just, sorry Louise,
yeah.
Sorry for being bossy.
Yes.
If you can move into the...
yeah, move in.
Or even stand up, even better.
Stand up, yeah.
Here.
Yeah. I suppose you'd have to approach it with care. So really in a way that if you know the person who you're going to be speaking to, you will know, someone how to operate. So it could be that you could open the conversation by saying, I've noticed that sometimes that, you're not the same when you drink, or you're not the same, when you take something. What are your thoughts? How do you think you are? around addiction, around alcohol or drugs, and let the person tell you what their sense of it is. Sometimes people can be defensive, reactive. It's best to not push it if they are, and sometimes it might be ideal because they might be waiting for you to ask, because a lot of times it's a very scary thing to admit and acknowledge an addiction. So sometimes somebody asking you can be a gateway into dealing with it. Also, sometimes I've heard of people leaving leaflets around, just leaving information around treatment and ways to manage it. And go, if it's very difficult for you, go to Al-Anon yourself until such time as the person wants to address it.
Perfect, thank you.
Is it on?
It is, yeah.
Yeah.
Okay, and please discuss dual diagnosis.
Okay, so dual diagnosis is where a person is presenting with more than one condition. So they're presenting with the addiction as the primary presentation, but they also have an underlying issue as well. So that could be anxiety, depression, all manner of different mental health issues. And they may not be aware of it even. They may never have been treated for that. So when people come into us, that's why Dr. O'Gara and his team are able to assess that, provide diagnosis and provide treatment options.
Yeah, and dual diagnosis spans, I think the word is an umbrella, or sorry, the term is umbrella really for an increasing amount of issues. Really, if you put addiction down one side and mental health and physical conditions along another, including maybe intellectual disability, you get a crib sheet, and there are many options, in that crib sheet of a combination of addiction and mental disorder across the other side, if that makes sense. So, okay, what advice can you give for someone who's been through 4 treatment programs and has relapsed again?
I would say never give up. So it's not uncommon. It can be very difficult for the person who's gone through several treatments, but sometimes you're actually closest to the recovery by the time you're at the very end of your tether, if that makes sense. So a lot of times the reason that people are relapsing is they just haven't quite got the insight, they just quite haven't got there, but that doesn't mean that they won't. And it usually means that if you're willing to go into treatment again and again, that speaks to your motivation and your sheer determination to recover. So we would always say to keep going, because I've seen that many times over the years, that when people finally get it, they exit the addiction cycle and they're out and they're home, so it's to keep going, really.
Yeah, that was really well said. Yeah, and just addiction is a chronic, relapsing, remitting condition, like a lot of other chronic, relapsing, remitting conditions, high blood pressure, diabetes, epilepsy. And addiction, in fairness, falls into that category. There is a concept of long-term recovery, though, just like you said, exiting the cycle.
Yeah.
And that's what we strive for. And it's got to be one of the best parts of the job, if not the reason we do the job, is to see people. People often ask us, well, how can you do that? How can you work with something that is so depressing or challenging, and the recidivism is so high? Yeah. It's because you see people getting into that long-term recovery. Yeah. And you mentioned outpatient review. That's probably one of the joys of meeting people who are in long-term recovery, and just feeling that pure joy from people.
Absolutely.
And the positive vibe. It's just amazing.
It's so worth it.
Okay. On average, how many patients attend or are admitted for the 28-day program?
Well, it varies, but for instance, right now there are 15 people on the program. And it's a rolling program, so as people discharge, more people are coming on. It's usually quite full. we generally will keep it for therapeutic reasons. We would keep it to around, that number 16-ish, because we can divide it into 8 then, and a therapist can take a group of 8 and another therapist take a group of 8. So that works really well. But we find that the numbers are always coming in, always full basically, and sometimes people waiting on a list.
Sorry for being pedantic about this. Can everybody hear? Yes, everybody can hear Louise. Perfect.
Yeah.
Now, in your aftercare program, say for gamblers, are they allowed to drink while in recovery? What an excellent question.
Yes.
It comes up all the time.
Yeah. So it's interesting, the word "are they allowed," and actually patients will ask us
exactly
that.
what I picked up on.
Yeah. People will come in and they kind of forget that they are, voluntarily coming into the program, voluntarily looking at the whole choice of a life of abstinence. But it's almost like addiction being what it is. There's a saying AA has that it's cunning, baffling and powerful. So sometimes if you put down one addiction, then the mind will just immediately divert to, well, what else can I do? I can't gamble, fine, but I'll have a look over here. I can keep drinking or I can keep using. Do you know? So we would not recommend it, and we would say it's an abstinence-based program, and really that the best action really is to remain abstinent and sort of stay away from mood-altering substances.
Excellent, thank you. Are addictive behaviours, Louise, caused by emotional problems? Is another question.
I don't think that there's a straightforward answer to that. I think that it can be it can be a component of the overall picture. Let's just say it's rare to meet somebody in addiction who hasn't got some background, either of trauma or dysfunction in the family, all the life stuff. So it's part of it, but it doesn't actually dictate that will primarily cause the addiction. I've worked with people who have very little really of trauma in their background. They just become addicted.
Okay, and binge eating disorder, I'm interested in what you have learned regarding this particular condition, which is another good question because it's obviously something you've done a lot of work on. Yeah. So your thoughts on binge eating disorder? I suppose one of the questions that comes up commonly in the literature is it an addiction?
Well, I can only offer my thoughts on it from working in the field. You could categorise it straight down the middle as an eating disorder. However, what I've seen over time is that there's so many facets of compulsivity to it that it's hard to not see that there's an addictive piece to it. That's what I would say, that it's the same thing, thinking about the actual food, planning it, going through it, recovering afterwards, feeling awful, clearing up, trying to hide it, starting it all over again, and all the rumination that goes with it. All of that, to me, mirrors the cycle of addiction. And many patients who suffer from both addiction and eating disorders will say to me, well, if I'm not drinking, I use the food. I use the food in an addictive way to numb out. So I would believe there's an addictive quality to it.
Okay, I'm just going to answer the next one and give you a small pause there, Louise. So you can't say afterwards that it was too hard, okay?
Yeah. I did all the work.
My 21-year-old son is addicted to cannabis. How does he go about self-referral for assessment for treatment? I.e., does he make an appointment or just come into the hospital? How long before he is admitted if he is approved for treatment? Excellent question. So the first part of that, how does he go about self-referral for assessment for treatment? We don't do self-referral, it is GP referral. The reason for that is not to be difficult, it is that we have a continuity of care if people leave the hospital. So if the GP isn't involved, we've learned over the years that it's much better for the GP to be involved if somebody leaves hospital particularly quickly. So that's the idea around that. So it would be a GP referral to ourselves, i.e. does he make an appointment or just come to the hospital? We don't do a walk-in service. It's an excellent question. Do you have to come for an appointment, or do I look at the referral and just admit you? Well, in a lot of cases I just look at the referral and admit you, but in some cases people want to come and see me first because they're not sure about whether they want to come in. In other cases they don't want to see me, they want to come straight into the hospital, that's fine. We look at and I say we, it's not just me that looks at referrals. In some cases it is when it's very obvious what should happen. But in some cases I'll discuss it with the team, and we are looking to admit people to our program, obviously, but sometimes it's not a fit for reasons that are sometimes obvious, and we discuss that with the GP, and very rarely it's not obvious, and we would discuss that again with the GP. Maybe we would suggest that an alternative program would be suitable, a longer program might be suitable, a program that would be more structured and kind of more rigid or more 12-step based might be a better option here, or a program that would be, not a private setting because perhaps it might appear to be too comfortable. That sometimes comes up. So there's many reasons as to why we would admit and why we wouldn't admit. But largely we would admit. I think most referrals that we get, we would admit. Yeah. But there are some exclusions for coming here. Sometimes, some presentations, this 21-year-old, if there are complications, for instance, with cannabis, if there's a forensic history of something we need to look at, maybe the environment here is not suitable for whatever reason. So it's often in the fine detail of the referral, and we'd look at that as well. But largely positive in admitting. So I would say to that to get GP to refer into us, and we'll take it from there.
Yeah, absolutely.
Okay.
Yeah.
Back to yourself now. Break is over, and we've
break.
loads of time. Loads. And Richard, you told us it's 9:30, so my God, we're yeah. And don't mind the documentary issue. You can. This is more important. I didn't say that. What is the price structure of the 28-day programs for an unemployed person? So I think that's a question for accounts, okay, and that's as clinicians we wouldn't get involved in that, but again it is an important question and one that we should be able to answer, so that's the telephone call to the accounts department, and they go through that structure with you. Does the amount of time one has been using determine on any level the rate of recovery or the quality of recovery is the behaviour aspect? Well, no, I think that's a separate. Does the amount of time one has been using determine on any level the rate of recovery? That is a good question.
Yeah. Well, not really, because people can come in, they can present with decades of use, and you can find that they're so committed to recovery and so open and willing and honest and just so done with the addiction that they do really well. Somebody else can come in and you would say, well, their addiction history is fairly short, but they may struggle quite a bit, again because the insight isn't quite there, and in some ways they don't feel or see it's quite the problem that it is. So it really varies. So it's hard. I wouldn't agree that it depends on how long you've been addicted. Basically, it's all to do with your attitude, I suppose, and how determined you are to leave this thing behind you.
Yeah. I totally agree. It can be related. We look at what they think called POA, or periods of abstinence, which often can be an indicator of the severity of the condition. So the longer the period of abstinence prior to presentation, and the more often they are, can be a positive indicator. If somebody's presenting with very few periods of abstinence, then it can be a negative indicator. However, we have learned over the years that it really is, it's about the person and where they're at, and the level of determination.
Yeah.
Sometimes the level of the consequences, how much people have, you know, this idea of rock bottom.
Yeah.
So are they truly at rock bottom, and
Yeah.
have they had enough of the behaviour and the consequences, fed up and genuinely want to move on? So it's mixed, isn't it?
It is mixed. Yeah.
And it is just a second bit of this, or is it the quality of the recovery? So is it you know, how much has that got to do with getting the long term? Getting the results.
Yeah. Again, I think everybody's so different. Every individual is so different. But I do feel that the thing around rock bottom is that, you know, it sounds harsh to say, but when a person has suffered enough, sometimes it's only then, when they hit the wall, that they actually reach that defining point where they say, I can't do this anymore. I'm just not able to do this. And then it's almost like they can shoot up quite quickly then. They don't have to reach that bottom, but it tends to be that a lot of people in addiction do, because again of the power of addiction. You know, it's very deceptive, and it will tell you, it's the one illness that will tell you don't have it for a long time.
You want to just mention anything else about insight? You mentioned that in your talk, and just about denial, the relationship between denial and insight, cracking denial, I think you said. I hadn't heard that before. I like that a lot.
Yeah.
Do you want to just say a little bit more about that and the cycle?
Well, just that denial is built up on defences. So the person is getting something from what they're using, so they don't want to give it up easily. Or rather, the addictive part doesn't want to let go. So, you know, while the harm is happening, the denial is strengthening. So in other words, it's saying there is no problem here, you don't need to look at this, you can manage it, keep going, it doesn't matter. And basically the insight is like drops of reality. Every time something very painful happens, it's like a breakthrough of the denial, and the person sees, it's like a moment of clarity where they actually get to see, my God, I'm really in a mess, I can really see it. Then the gap might close again, but it never closes fully. You can't unlearn what you've learned. So that's the good thing about going back to treatment. You know, even relapse can be positive, because every time you have another relapse, you're that bit further to the resolution and long-term recovery. And that's why we say never give up.
And that's an antidote to the concept of revolving door treatment. That this is a never-ending circle, really. That you're just continuously admitting people doing the same thing, and it's going nowhere.
Yeah.
I mean, I would, again, question that in the context of other chronic medical illnesses, and if you're suffering other chronic medical illnesses, why is that not criticised, that you're going back to hospital time and time again? So, our sense as a team is that nobody chooses to be in this situation. Nobody chooses to have this level of suffering. Just like nobody chooses to go to up to St. Vincent's or any of the other hospitals with a chronic medical illness. But as you're saying, these periods of insight is the start of the journey to long-term recovery.
Absolutely, and that's progressive. So just like addiction is progressive, recovery is progressive. And that's why the meetings are so helpful, because the more that the denial is dissolved, the more you see of the real picture. And then, of course, you get benefits in recovery, and that then gives you the motivation to keep going. And it's almost like a fog lifts. People will often say that 6 months down the road, a year, they say, I cannot believe I couldn't see where I was at, because they couldn't. You know, it's not willful. Who would get up in the morning and say, I'm going to become addicted and I'm going to harm myself and everyone around me? Who would? So it's not about being willful. It's about the unconscious being made conscious.
Okay, do you want to just mention for people who have attended tonight just the importance of mutual support meetings, maybe, because you just mentioned meetings there.
Yeah, I suppose because I've worked in this field for a long number of years and I have seen the fruits, I suppose, of people attending 12-step fellowship meetings, life-ring meetings. I suppose what I would have witnessed is that there's something about, the repetition bringing recognition. So think about it. If you have a serious illness and you leave hospital, you're going to convalesce, but you don't really need to study it or, review it or think about it too much. You just hopefully get on with your life. Addiction is not like that. With addiction, the risk is everywhere. For instance, if you're a drinker, you're going to get possibly a craving or a trigger at any point. So you have to remain vigilant, if you like. So the point of going to the meetings is to reinforce the message. Oh, that's right, I can't drink safely. Right, I can't, because what will come is the temptation to go back. Patients talk a lot about becoming complacent, and that can happen all the time. People can work really hard for their recovery. They're doing really well. Everything has plateaued and worked out. And then suddenly, a year down the road, they're at an event and they see a glass of champagne and they say, what the hell? One isn't going to hurt, is it? And it's that whole thing of pain has no memory. So it's like the experience they felt back then is not present with them. It's not up there to warn them. And they take the one glass and they're back. So that's why meetings help to remind people of the cycle, of where they've come from, of where it brought them and where it can bring them again. And also the power of being with peers. There's something, and the guys would say it on the programme, there's nothing like sitting with a group of people who are nodding when you're telling them the most awful stories about things you did or got up to, and there's that sense of camaraderie where somebody beside you says, I know exactly, do you want to hear what I did? So it's not that they're making light of it, but there's huge connection in these meetings, and they work, because I've seen that over time. People with 20, 30, 40 years of recovery, and it's not an issue. They are living their lives. They're living their lives. They're dipping into meetings when they need them, but they're living their lives without the obsession of the addiction.
Okay, lovely. And meetings are life-ring is 7:30, general meeting, just down the main corridor for anybody who wants to attend. There's no cost attached to any of these meetings. That's 7:30 Monday and Friday, and Wednesday evening is women's only meeting. That's life-ring, which we introduced here about 8 or 9 years ago. Secular, it is does not invest in a higher power, and talks about what happened during the last week. The alternative to that is AA, which is available 10:30 every morning and 7:30 every evening, Monday through to Sunday. I'm 99% sure I've got that right. And AA is, again, no cost associated with it, and a decent evidence base to support AA's efficacy in the international literature, and we pretty much across the board would be recommending one of those inputs. I've often used the phrase AA is head and shoulders above any treatment available. I don't have a problem repeating that, because really, such a network of AA nationwide, no cost associated with it, and it does get results, particularly if you do active service and get sponsorship. So that's my little spiel on AA. Moving swiftly on, a question about Oxy, OXY, and just, is it addictive? There's not enough information on this. There are tablets called OxyContin and OxyNorm, which are opioid medications, and as you're probably aware, there is a crisis in the US at the moment with opioid medication. and it is something that we treat, but again, it's all in the referral to us, because some opioid addiction needs substitution therapy, i.e. methadone or another drug called buprenorphine, and that's the type of thing we need to look at in the referrals. So, I think this is definitely going to be a very, very big issue going forward. I think that's what the question is, so hopefully we've answered that. Louise, can a person go to Pilates yoga classes without being in hospital but has an addiction?
Well, really, if you do engage in the program, you've got to come in as an inpatient and spend the 28 days. Of course, you can attend, outside yoga classes and Pilates, and I'm sure there's many of them abound, and they would be helpful if somebody is struggling with addiction, but not to come in as a day patient to do those activities now.
Okay, and how common is prescription drug and codeine abuse?
I would say it's huge. Absolutely. In terms of the numbers we've gotten in, I think you'll agree.
Yes,
just,
very common.
Yeah, Sulfadine, Nurofen Plus, cough bottles. Like, it's amazing. And a lot of times people switch, so they may have got an alcohol problem under control, and they'll, go along quite nicely for a year or two, and then they realise that there's a kind of, some sort of a buzz or whatever from taking medication. They might come upon it accidentally, and then suddenly it's a huge problem, and they need, excessive amounts of it on a daily basis to function, and then the problems in that area start again. So I'd say it's a growing problem.
Thank you, Louise. And do you offer public beds for addiction? Unfortunately, at present we do not. Is this program an option for someone diagnosed with Alzheimer's and is alcohol dependent, brackets in their 70s? Is there any other options with dementia and alcohol? So the first, is this program an option for someone diagnosed with Alzheimer's and is alcohol dependent in their 70s? Do you want to talk about cognitive impairment and alcoholism, wet brain, etc. just briefly, because we see a lot of cognitive impairment in the program.
We do, yeah. And it's very difficult when you see people who have become so cognitively impaired. It's shocking, really. People who are the brightest and the best, and yet their cognitive function is really disimproved. Dr. Watchorn, the psychologist, and the whole team will carry out assessments in that area, and we'll make a decision then on whether the person is able to withstand the rigours of the programme, because it is quite rigorous. It's full on. There's groups all day, every day, and there's educational pieces to it. So there's a decision made on whether the person would be able for it, and whether it's fair on them to join a group where they may not feel that they're able to keep up with. Corsicus is the term for wet brain, and we see that from time to time also, and that's where the brain has, literally wet brain, where the brain ceases to function because the person has been using for so long over such a period, and sometimes with huge intensity of intake. So we do see that, and we just make a decision at the team level on how to manage that.
Yeah, absolutely. Moving though to the idea of Alzheimer's and a diagnosis of Alzheimer's, where there is comorbid alcohol use, that is not an uncommon situation. And again, I referred to a crib sheet earlier where you would have diagnosis down one side and mental disorder along the other. So in this case, you'd have Alzheimer's on one side and alcohol dependence down the other. So that's a particular dual diagnosis situation. So I think in this case, we would be looking at to collaborate with our colleagues in psychiatry of later life, and for them to give an opinion on this as well. And it all boils down to the level of cognitive impairment. So it would start with a GP referral into the hospital, and it would be reviewed by not only ourselves but the psychiatry of later life team. I hope that answers that. And related, can a person with dementia get a real insight into the reasons behind their addiction? They might be able to, but again, of course, it is dependent on the level of cognitive impairment, and that question would be best answered by an expert in dementia. And we have that expertise here at the hospital, and we can collaborate with our colleagues in that regard. Can treatment be on an outpatient basis? It again starts with a GP referral, and yes, we do offer outpatient treatment. No, everybody certainly does not come in for the programme. So that would start with a GP referral. I or we would have a look at that and work out an outpatient plan. The outpatient plan might be attendance of myself, mutual support meetings, and one-to-one counselling. That is generally the triad that we would recommend, and we have a number of counsellors that we work closely with on the outside, either that have worked here or that are well known, but it tends to be a very tight group that we use, because we need to have a very good connection with those counsellors. I've already talked about meetings, and then there might be appointments with myself. So that would be a summary of the outpatient approach, but again, it might not be exclusively with me or us. We could recommend somewhere else. Sometimes people don't want treatment in Ireland, they want to go abroad. So there's an example. We're almost done, and then I think I have put nearly everything to you, I think. So just medical card, costs of rehab. I think unfortunately medical card would not be cover the costs here. Do you do anything on food addictions?
Well, we do have a ward that works with eating disorders. It's specifically catered to that disorder. So in that case, the same process would apply, where you go through the GP, refer the person in, and there's a great clinical team there to work with that.
Yeah, so we have an eating disorders unit here, and we often see food addiction as part of a comorbidity with other conditions. It's not uncommon for us to see people who have had, for instance, gastric banding and then go on to develop other addictions and other process addictions. So there's this constant interplay or crossover between the different addictions. So again, that would be, if somebody's considering getting treatment here for that, it would be again a referral, start with a GP. Okay, Louise. What is the difference in the management of patients who don't get admitted to hospital and are managed in the community HSE programs? Difficult question. I don't think we can comment on the HSE addiction programs, but generally, what do you feel the hospital, I guess, offers? I guess the inpatient, the rehab element, isn't it?
Yeah, absolutely. The 28-day program is what we would offer. There are, of course, supports in the community. It varies from catchment area to, catchment area. Some are rich with support services in addiction. You'd probably look it up, through the local health centres. And a lot of the patients would say, the further out you get from Dublin, there's kind of less and less support services. But some patients will link in with them quite successfully alongside mutual support or coming back up to see Dr. O'Gara.
And the last question, and thanks guys for your attention. And I like this particularly because I think it's referring to stigma. Stigma and mental health. Mental health issues aren't as obvious as, let's say, a person walking around with a physical ailment. I totally agree. Like a missing leg. Has there been any progress in shedding more light on mental health for people on the outside looking in to help them get a better understanding?
That's a really interesting question.
I think the family day piece here and the educational piece
really
is
helps.
our contribution really to help people directly affected by addiction, but also by you doing this talk tonight, I think is sharing education. I'm answering this for you.
Yes, you are.
I think the we constantly battle with negative attitudes
we do.
and negative views towards mental illness, and it really is something that is I think it's at times annoying for us, isn't it?
Well, that's the word that was coming to mind.
Frustrating.
It can be frustrating. Sometimes I feel saddened by it. that there, you know, people have to suffer along with the, you know, serious, devastating illness that is addiction. They also then have to contend with the stigma. So like that, if you go into a hospital for a physical ailment, patients would often say you get lots of attention, and that's awful, how can we help? Not so with addiction. You know, a lot of times people will be, they can be judgmental, they can be directive, they can say, you know, just get on with it, and why are you even going into hospital, you should be able to do this yourself, on and on. So a lot of it is to do with, you know, lack of information, not knowing all of the facts. But stigma, you know, it definitely causes a lot of suffering for patients and their families, and I hope that that's changing.
Well said. I absolutely spot on. I think it is something that irks us a lot, and it's something that we feel passionately about, and it's something that we really want to try and reduce, because it is an impediment to getting well. When there are negative attitudes out there, I think, you know, the suffering is compounded by stigmatized attitudes, and hopefully there is a sense, I think, you know, with particularly with some younger people coming through, and some initiatives on social media, that this is changing. But it's very difficult to change attitudes. A lot of the surveys, particularly Royal College of Psychiatrists survey in London, which looked at stigmatized attitudes and tried to change it, the Changing Minds campaign, really demonstrated that it's very difficult to change minds around this. But it seems to be, we seem to be doing better. So, and your talk certainly tonight, I think, has helped that. So thanks, Louise, so much for tonight, for the fantastic talk. Thank you very much.